What is TACE?
Transarterial therapy. Transarterial chemotherapy is TACE and transarterial radiotherapy is TARE. From the common femoral artery in the groin area, we enter very selectively into the artery which is supplying that part of the liver tumor. Once we enter into that artery, then we inject either a chemotherapeutic drug, so that becomes TACE, transarterial chemoembolization. If we inject a radiation emitting particle, then it becomes TARE.
Which subset of hepatocellular carcinoma is an ideal profile eligible for this kind of a management?
Early and intermediate stage of HCC. Subset of patients that are fit for TACE or TARE. The recommendation says that it is the intermediate stage HCC, means there are multinodular tumor, so 3 or more than 3 in number, which are not upfront candidate for either resection or transplant. Patients which are fit for transplant or which are as lesion wise, which are okay for transplant or ablation, but are not good candidate for other reasons.
What is intermediate stage cancer in liver carcinomas, and how does a referring physician know about the diagnosis of same?
Once on a triple phase CT with or without alpha fetoprotein, we know that it is HCC. The next thing is to just make out whether the patient is fit for a surgical approach or we should send the patient to interventional radiologist. So usually very early and early tumors are fit for either surgical approach by either resection or by doing a transplant. Find multinodular tumor, or if they're finding 2 very bulky tumor with high alpha fetoprotein, it is usually intermediate stage HCC and they should refer the person to interventional radiologist. The patient should not be overtly icteric. There should not be any clinically obvious features of portal hypertension.
What are the current guideline recommendations for these patients with TACE and TARE?
The standard BCLC, which is the Barcelona Clinic Liver Cancer classification, the TACE and TARE, they have found an important place in the management of all through the subset, even in very early. In intermediate, it is the standard of care, and even now in advanced stage HCC, there is a place for TARE. Though patients who are going for transplant, but they have a long waiting period for any reason.
How is this beneficial in comparison to the conventional surgical alternate?
There is no need of surgery. The thing is nearly scarless, and the post-operative liver decompensation is less common as compared to a standard right hepatectomy.
What is the message you want to give to the general physicians about managing their patients in the OPD after the procedure has been done by an interventional radiologist?
Make sure they do send the patients back to us, because the background liver is cirrhotic. The patient needs to be in constant follow-up for any early recurrence or any residual disease. To look for signs of any post-TACE liver cell failure, liver decompensation, to detect any post-TACE complication. Sometimes we require MR, triple phase MR and not CT. Look for signs of liver failure, look for any early complications like any increase in jaundice, fever, increase in ascites, and a constant follow-up, lifetime follow-up is maintained.